Hello and welcome to this special podcast about the problems we can have with our knees and the latest developments in knee surgery available from the team at York's Clifton Park Hospital. I'm Jonathan Cowap of YO1 Radio and our expert guest today is Mr. Tony Gibbon from Clifton Park Hospital. Hello.
Hi.
Welcome to the studio. You are Mr. Knees, I understand. That is what you specialise in, that's what you do.
Absolutely. There are a number of us specialising in different fields of orthopaedics, and I'm one of two or three specialist knee surgeons. I've been in York for nearly 27 years as a consultant, and during that time orthopaedics has expanded quite considerably. Clifton Park Hospital, we've been fortunate enough to work at for over 18 years, and that's where the bulk of elective or planned orthopaedic surgery, both NHS and private, takes place in York.
Tell us about Clifton Park Hospital, because it might be a hospital that many people have not heard of. They'll know the main hospital on Wigington Road.
Absolutely. So Clifton Park was established, as I say, over 18 years ago, initially as part of a government strategy to create what was labelled an NHS spine chain of independent sector treatment centres. So in other words, they're privately run hospitals to deliver surgery to predominantly NHS patients as a means of tackling waiting lists and addressing lack of capacity in the NHS acute sector. And certainly in York, that's been a lifeline for us in orthopaedics, to the extent, as I say, that the bulk of planned orthopaedic surgery takes place there. Over the years, the management has changed, but it is independently run, so it's not part of the NHS management structure, but still over 80% of the activity there is funded by the NHS and delivered by surgeons who have all worked as consultants in the NHS for a long period of time.
So it's not actually you wouldn't classify it as a private hospital then, or is it?
Well, it is a private hospital. I mean, if you compare it with the Nuffield, for example, which people perceive as a private hospital, the Nuffield Hospital delivers a lot of similar care to NHS patients as well. So by independently run, it is a private institution. It's by a global health organisation called Ramsay Healthcare, which is an Australian parent company, but they have hospitals throughout the world, both in Australia, Southeast Asia, and other parts of Europe. They have a big presence in Scandinavia and also in France in particular.
A very respectable background then. Let's get down to the nitty-gritty. Let's talk about knees. Why are knees so vulnerable?
Well, I think all joints have their vulnerabilities. Knees, obviously, don't have to explain, are load-bearing. But it's a complex joint which moves in lots of different directions. It's not a simple hinge. It rotates. There's the kneecap at the front, and I could bore you for hours about the mechanics of the knee joint. But obviously, in simple terms, my practice has been dealing with developmental problems. So some people are born with wobbly kneecaps, for want of a better expression, sports injuries. So football, we sometimes jokingly regard not as a sport, but a disease of the knee. Skiers, netball players, hockey players, it's vulnerable not just in direct contact, in rugby, for example, or football, but also vigorous pivoting, twisting movements can cause ligament damage, cartilage damage, etc., etc. And then obviously, sometimes as a consequence of those, but more often just intrinsically, some people are prone to develop arthritis, which is wear and tear of the bearing surface cartilage, the articular cartilage, and with age that becomes more prevalent. Often those patients with arthritis will have a family history. My dad had a knee replacement, my granny had a knee replacement, and so my practice is treating those young people with conditions like that, as well as the older patient with arthritis.
How long has knee replacement surgery been on the go? I mean, you say that you've been a surgeon, you were at York Hospital for 27 years or something like that. Has knee replacement surgery always been going on, and how is it improving?
So knee replacement surgery has been around for decades. Certainly, 40, 50 years ago, when the first ones were implanted. I think what's happened over the years, the demand has increased dramatically for a variety of reasons.
We're living longer.
Exactly. But also the growth in implantation, the peak is not just in the older patient, but in the younger patient as well. So I've replaced people's knees who are in their 40s as well as their 90s. So people are never, inverted commas, too old. Obviously, one is very cautious in considering joint replacement, putting metal and plastic into a younger patient, because obviously there's a potential for limited lifespan of the implant. So it's a myth that they only last 10 years and then that's it. Now, having been, as you say, in York for that period of time, I commonly see patients who said, "Oh, you did my other knee," and I said, "Oh, and when was that?" And they say, "Oh, 1999, you know, and it's still functioning very well." So obviously, the longer an implant has been in, it can wear out and wear loose. But, you know, thankfully, it's a very successful procedure. But also, to answer the second part of your question, there's been an increase in demand. Also, our confidence as surgeons in outcomes has improved. That isn't to say that some patients feel it's potentially an ordeal and doesn't always fulfill all their expectations. But, you know, I replace over 300 knees a year. And obviously, if you do the maths, that's several thousand over that period of time.
It's a lot of knees.
But also, developments have included partial knee replacement. So, in simple terms, a knee replacement is a metal and plastic bearing, a metal cap on the end of the thigh bone, a metal plate on top of the shin bone with a keel inside, and then a plastic liner in between. Obviously, a partial knee replacement, some patients only have predominantly the inner half of the knee worn out. And so those of us who have confidence in that technique see it an act of vandalism to take away the rest of the joint, which is still healthy, because it's not necessary to remove. And that, you know, we're commonly doing that as a day case nowadays. So anaesthetic techniques have improved. So we've got more confidence in surgical techniques. Some surgeons are using robotics to theoretically improve the alignment of the joint. The materials, strangely, haven't changed dramatically over the years. It's still, the metal bit is a cobalt chrome alloy, and the plastic, the polyethylene, high density polyethylene, is pretty much what's always been used. Subtle changes have been made to the chemistry of the plastic over the years. Geometry of the implants has evolved as well. So we're always thinking that the latest designs are improved demand, as, you know, the patient profile has changed. When these operations were invented, they were, you know, targeting the elderly person who was almost chair-bound, who could barely get out of the house. Now we're implanting joints into patients who want to climb mountains and go skiing and play sport, which they do successfully, thankfully. And so the stakes are higher. Patients' expectations and surgeons' expectations have evolved over the years as well.
I'm fascinated by your reference to robotics there. What part do robotics play in knee replacements?
The success of a knee replacement is determined by, obviously, how it's put in. Obviously, patients come in lots of different shapes and sizes. Implants do so always, but not as many shapes and sizes as patients. So the key to the success of the operation is making sure the implant is the right size. We talk about balance. In other words, when the bones are cut, there's a space between the ends of the bones. We talk about the flexion gap and the extension gap. Those spaces have got to be created very accurately. So the knee has got to be properly aligned and stable, so it isn't loose or wobbly.
Is this what the robot does then?
Well, the robot is an additional tool. We have some traditional mechanical tools to measure where we put the cuts, and obviously, like every joiner would say, measure twice and cut once. So robotics, it's not like a Dalek that comes in and does the operation for you.
I'm glad to hear it.
It's a fancy tool which helps the surgeon calculate those cuts theoretically more finely.
We talk about sort of preserving our knee health. Is there such a thing as knee health? Because I'm thinking, as you've referred to several times, as all of us get older, as we've worn our knees out with our lifestyle and whatever we've been doing, or maybe we're just susceptible to conditions like arthritis, is there something that we can do to keep our knees in good working order? And does there come a point at which somebody who thinks their knees might be on the decline needs to come and talk to someone like you or one of your colleagues?
Yes, I mean, I'm obviously faced with this question on a daily basis. I mean, the first thing to say is, you know, you can't do any harm by doing as much as the knees will let you. And even if it hurts a bit, carry on doing it, because if you sit around with your feet up, it'll just get weak and stiff and potentially feel worse.
So keep on using it.
Absolutely. So strength and conditioning training is often very valuable, even with evolving arthritic symptoms. Simple painkillers can help. So obviously the time to seek advice is when you're worried or concerned about it. And there are a variety of mechanisms for seeking that advice. Many GP surgeries have an in-house physiotherapist, or, if patients struggle to access that route, then obviously many of us are available to see patients independently.
Does there come a trigger point, though, at which someone from your profession says, you've taken the painkillers, you've had the injections, you've done the physiotherapy, whatever it might be, to try and maintain your knees in some kind of working order, but now we now need to start think about surgery?
Symptoms are very subjective, and I've seen tens of thousands of patients, obviously, during that time period. Every day, people will come to me, look at the X-ray, and ask me to tell them how bad it is. But I turn that around and say, look, it's as bad. Symptoms are very subjective, and it's as bad as you tell me it is, or it's as bad as the extent it's affecting your daily life. When I'm teaching trainees and the medical students, they can talk to folk all day and not come to a conclusion without structured dialogue. And so I tell them to ask patients, 4 questions. How far can you walk comfortably? Do you get pain at rest? Do you get pain at night? And what can't you do that you think someone of your healthy age someone who's healthy at your age should be able to do? And obviously for some patients, if they can get around the supermarket and have a rest at the end, they don't trouble themselves with an operation. On the other hand, if somebody's worked hard all their life and want to go hill walking or play golf and the knee stop them doing it, that is enough to make them miserable enough to consider surgery. So it's never too late to have something done. Certainly we would caution, people whose arthritis doesn't appear that severe on an X-ray to try and avoid surgery as long as possible. But I think there are many popular myths out there, as I was alluding to earlier. It isn't a 10-year lifetime and then there's nothing more to be done. So the threshold for intervention is that discussion between us and the patient. As I say, the symptoms are very subjective. One patient's screaming agony is another person's a bit of a nuisance, and that's not a reflection on their personality. It's just the way different symptoms evolve.
Let's talk about the surgery itself, because inevitably for some people, surgery will come about. How long does knee replacement surgery take?
When a patient's been scheduled for surgery, they give written consent at the time and are given all written information following that discussion. Then, prior to admission, they are screened and seen by an anaesthetic nursing team with routine blood tests and heart tracing and ECG, etc. Patients are admitted on the day of the operation, seen by the anaesthetist and the surgical team prior to going to the theatre, and then obviously the nursing team. The operation is usually done under what's called a spinal anaesthetic, which is an injection in the back, which numbs the legs from the waist down. Most people are sedated, so as far as they're concerned, they're asleep, although some patients are quite keen to hear what's going on. No one sees what's going on, but some people are quite happy to chat away to members of the team whilst we're operating. The anaesthetic is and some patients have a standard general anaesthetic for either out of choice or because the anaesthetist feels that's more appropriate for them. Patient is then taken in the adjoining operating theatre where the lower leg, where the limb, the knee is cleaned using antiseptic solution. The tourniquet is usually applied to the upper thigh. The operation itself takes less than an hour usually.
That quickly?
Well, from the incision to the dressing being applied is usually less than an hour in the majority of cases. The patient's usually away from their room or the ward for a couple of hours or so. At the end of the procedure, simple dressing is applied. Some colleagues use a big bandage, but I don't require one. The wound is usually closed without any external devices. So in other words, we no longer use staples or clips, and there are no outside sutures to be removed subsequently, which is much more convenient and certainly more comfortable and tolerable for the patient.
Why is that? Why have you changed? I mean, I think most people would expect to wake up and find that there were clips there, or there were sutures, there were stitches there.
Well, again, techniques have evolved. Modern suture materials we use nowadays what are called knotless sutures. So in simple terms, it's a polymer, not plastic as such, but it's a polymer which has barbs on. So that we found that works well. And certainly reduces the risk of infection, and well tolerated by patients. And patients who I've used clips on years ago come back and have this, and they say, "Oh, I'm glad I didn't have to have those clips out."
When somebody comes round from knee surgery, how common is pain? Can you presumably it must cause some pain, this intrusive process of cutting bone and...
Absolutely. So, obviously, never having had a knee replacement, I can't give you an accurate description, but I can talk about what patients tell me. Obviously, if a patient has a spinal anaesthetic, when they come round, as you say, or when they wake up from the procedure, they don't have any pain because their legs are still numb. And obviously, at the same time, in anticipation of discomfort, they're given drugs to reduce the onset of painful symptoms. And again, just as the preoperative symptoms are subjective, pain is very subjective. Our goal is to minimise that as much as possible. We can't get rid of it completely. But nowadays, some patients having knee replacement are going home on the same day, are comfortable and well enough to do that. Our average length of stay for total knee replacement is less than a day and a half. So, the majority would stay overnight and go home the next day. So patients don't go home until we're happy that they're safe, comfortable and confident.
This does seem to be very common, though, with a lot of surgery these days, where in days gone by, maybe 30 or 40 years ago, people would spend many days in hospital. And it seems to be, in the world of orthopaedics these days anyway, that the message is get up and get on with your life as soon as you can.
Well, that's healthy, and it reduces risk of complications. And also from a psychological point of view, most of us will be happier in our own environment. Obviously, we don't want people to go home and feel anxious, but pain, as you say, is inevitable following such what some people might call brutal surgery. And that is very variable, but there will be some discomfort following a knee replacement. A total knee replacement patient, there's a spectrum of, some people said I hardly took any painkillers, and some people, experience genuine discomfort for a number of weeks. But I think part of our role is to reassure people that that's a different pain to the arthritic pain. So it's pain as a consequence of the trauma that surgeons have inflicted, with inevitable trauma, and that gets better. But it can last for 2 or 3 months sometimes. Having said that, plenty of folk are driving within a short number of weeks, and people who are working, even heavy manual workers are back within a couple of months or so.
What would you say was the sort of total recovery period following knee surgery? Is that a how long is a piece of string type question, depending on the individual?
Knee surgery covers a variety of interventions, but speaking specifically about knee replacement, I tell my patients that, and I'm talking about total knee replacement rather than partial knee replacement. Partial knee replacements get better much quicker. I saw an 80-year-old lady today who had a partial knee replacement 6 weeks ago, and you wouldn't, watching her, you wouldn't know she'd had an operation. And she's a bit sore, but she's delighted with not to have the pain she had preoperatively. Total knee replacement patients will often have some discomfort requiring painkillers for 2 or 3 months after the operation, and I encourage them to continue taking them when necessary. But even those total knee replacement patients who come back at 6 weeks saying it's fantastic, which is by no means everybody, even they will say their symptoms currently improving for 9 to 12 months afterwards. It doesn't mean it's going to be troublesome for 9 to 12 months. It just means that it feels even better as time progresses.
I just find it very satisfying.
It's very humbling.
When you see the 80-year-old lady who hobbled in agony weeks and weeks ago, and you see her now moving about with much greater ease and less pain or no pain at all.
Well, absolutely. It's very humbling and a privilege, really, to be able to help people like that.
You've mentioned a couple of times myths and things, and one myth that you're very keen to bust is the myth that a knee replacement will only last you 10 years. Can you do something to make a knee replacement last longer? Do some people need another one within 5 years, or do other people living with their knee replacement happily 25 years later?
Well, all of the above, really. So firstly, the risks associated with knee replacement include infection. And whilst we go to extreme lengths to reduce those risks, sometimes due to patient factors or factors outside our control, infection can occur. And that is probably one of the common reasons for further surgical intervention being warranted in the early stages. But still, the majority of knees, when people talk about knees wearing out or wearing loose or needing to be done, that is usually due to loosening of the implant, what we call aseptic loosening, which is where the metal cap or the metal plate becomes debonded from the bone. And as a consequence of that, you can get bone loss. And then the loosening or the lack of firm fixation of the implant results in discomfort.
Is that something that somebody has done that causes that to happen?
Not
or is
particularly.
that just the nature of the materials or the procedure or just bad luck?
Again, any of those. It's not usually a traumatic insult. Patients may feel that an event precipitated it, but often that event in a normal joint or a non-failing joint would not have had that consequence, if that makes sense. So the mechanisms of failure, aseptic loosening is where the bone softens, for want of better expression, or becomes degraded as a consequence of debris in the joint, which causes an inflammatory response to weaken the bone. Or the plastic liner can wear out. So there's nothing really a patient, often many of those factors are outside the patient's control. Reasons of failure include, or accelerated failure can be influenced by malalignment, in other words, it not being put in the best position. For example, I did a redo knee replacement a couple of days ago on a gentleman in his late 60s who'd had the implant put in 18 years ago. And the findings there we were aware of before surgery, but the femoral component or the cap on the end of the thigh bone, was completely loose, and we could lift it out. It wasn't attached to the bone anymore because the bone had become weakened. And but he's going home today, 48 hours after surgery, without any walking aids. I mean, he's obviously uncomfortable because we've had to put a bit more metal in there than he had before. He asked me how long this one will last, and I'll say, well, forever, hopefully.
You've told us an awful lot about knee surgery, about knee replacements. Is there anything that you haven't touched on that you'd like to tell us? I mean, I'd be interested to know what you think the future holds for this surgery. Are there fresh developments coming down the line all the time?
Other technologies include patient-specific implants. So in other words, images are taken of a patient's body or joint, and an implant is custom-made. Now, the technology is available for that. It's expensive. Now, the theoretical advantage is in that one doesn't have to have a storeroom full of implants of all different shapes and sizes.
Like having a very expensive bespoke pair of shoes made for you.
Exactly, rather than having a warehouse full of ones to choose from. So one of the biggest challenges we face is managing both demand and expectation. Some patients who are in genuine need of treatment struggle to access it by the NHS through no fault of the system or theirs. And so there's a growing demand. That's the biggest challenge, I think, and seeing the right people at the right time. There are developments of some injectable therapies, some of which are still in evolution. Joint preservation techniques, such as what we call biologics, in other words, resurfacing techniques, but all of these are more expensive and as yet untested convincingly. Part of the problem is that by the time people get disabling symptoms, the damage has already been done. And so that's when we end up with having to put metal and plastic in there. So there's still a lot that we don't know, really.
If there's someone listening to us and they are experiencing knee pain, but they are hesitant, they are a bit trepidatious about whether or not to go ahead and have knee surgery done, have a knee replacement done, as someone who's been in the profession for a number of decades, what would your message to that person be?
Firstly, there are lots of popular myths. There'll be somebody who says, don't have it done, it's awful. And there'll be lots of people saying it's the best thing that ever happened to me. I've had this conversation tens of thousands of times over the last few decades, including with friends, relatives, all sorts of folk. And I have a few lines, if you like, that I say, well, as I mentioned earlier, the problem is as bad as it feels to you. Ignore what anybody else says. Similarly, go and speak to somebody. Only you will know. When people say to me, do you think I need a knee replacement? I'll say, what do you think? It's as bad as it feels to you. And then the other question is that, I don't expect people to come crawling in begging for a knee replacement, but equally they've got to be confident that it's their decision and it's the right decision. Now, some people will need reassurance. Some people need encouragement from their family, friends, relatives, etc., who've seen their functional deterioration. But the advice really is if you're not sure, go and seek advice from a professional, be it the physiotherapist or the GP or ourselves, because there will be a variety of opinion. I see patients who've been, I will say, discouraged by some of those other professionals. But ultimately, it's often sometimes patients that, some of our most grateful patients are those who we don't operate on, who've said, thanks, doctor, you've really clearly explained it, and now I know what my options are, but I'll put up with it for a bit or whatever. So it's having that opportunity to have their symptoms properly assessed.
Tony Gibbon, Mr. Gibbon, thank you very much indeed for sharing your insight, your knowledge, your experience with us today. And I sincerely hope that anybody's listening to this who's had questions about the whole whys and wherefores of having knee surgery, knee replacement, has had them answered by you during our podcast. Thank you very much.
It's a pleasure.